Hi everybody, this is Dr. Sloan. This is going to be pulmonary part 2. And I backed up a little bit into chest injuries, just a slide or two from where we ended part 1. And we'll plow ahead from here. If I can figure out how to get the slide to move forward. Okay. So we talked about pneumothorax. And I was thinking after I got done recording the other part that one of the things that is kind of hard to understand with bleb rupture, because a bleb is right here on the outside of the lung, is when this bleb ruptures, air from the lung is going to come in and fill up this space. Versus if you have a broken rib or an outside, open chest trauma, then air is going to come in from the outside, and this whole lining in here will still hopefully be intact. It may or may not be intact depending on the injury. But the air can come in from the environment, or the air can come from the lung that's inflated when there becomes a hole in the lung, and it can leak into this space in here, this pleural space. So just wanted to clarify that a little bit for you. Okay, so how will you know that your patient has a pneumothorax? Well, hopefully you're doing good lung assessment, you're doing good breath sounds, and you will actually hear the absence of breath sounds on the affected side. You may see cyanosis because, again, they're going to have hypoxemia because they cannot get enough oxygen into their blood and then into their tissues, which turns into hypoxia. Decreased chest expansion because our lung on that side is not working. Dyspnea. Sharp chest pain, subcutaneous emphysemas, meaning again that the air from the lung or the air in the space may actually try to work its way out of the body, and you may actually feel like little air bubbles on the chest, on the chest when you're feeling, or maybe even when you're putting your stethoscope down to breathe. It's a very strange thing. It's called crepitus. And it's like a crackling or popping kind of sound. And you only have to feel it once to really know what that is. It's really very bizarre. Elevated heart rate, elevated respiratory rate, and you may even have tracheal deviation with attention pneumothorax. So again, you may have something where, the trachea is off to one side. Your patient will also be very anxious if they're awake. They'll be very anxious, very concerned, will feel like they can't breathe, will really be looking to you for reassurance. So we're going to put on oxygen, and we're probably going to go for a pretty high concentration because we want the oxygen coming into this lung to be as fully oxygenated as possible so that we can hopefully meet the needs of the body. We'll put them in Fowler's position, which is basically a sitting up position, right? They could be in bed, but you want the head of the bed all the way up. And then prepare for chest tube placement and continued assessment. And for you, chest tube placement may just be ordering the chest tube tray from your carts, or if you have it on the floor, going and getting that for the physician. And then maybe also being prepared to give some kind of medication for anxiety for the patient as well. Atelectasis, we talked about this in class, but it's incomplete expansion of the lung or portion of the lung. Actually, this picture shows a collapsed lung, which really does not fit with atelectasis. But atelectasis is really just those little tiny alveoli get collapsed. And it happens, 90% of it happens after general anesthesia. So we can prevent or reverse with turning, coughing, deep breathing, early ambulation. And again, symptoms are really similar to what you will see with a pneumothorax, but on a less intense scale. So tachypnea, tachycardia, dyspnea. You may see cyanosis. Usually I would say what I have seen the most working on a post-op floor is tachycardia and tachypnea, and maybe even a low-grade fever, like 100 or 100.5. Not quite up there enough to really count as a true, febrile condition, but enough to make you say, what's going on in there? And again, instead of spirometer, getting these patients up, walking around is really the key here. That's why early ambulation is just so important from so many levels, not just pulmonary, but even circulation. And yeah, our bodies are made to move, and we feel better when we do that, even if we've just had surgery. So here we go. Victim of a gunshot wound to the chest, sustained a penetrating injury. Emergency medical response team applied a non-porous dressing over the victim's sucking chest wound. Okay, so every time this patient breathes in, air is going to be pulled in from the environment into that area. On arrival at the emergency department, the victim is cyanotic, and the nurse notes subcutaneous emphysema. So that's what we were talking about, that crepitus, that crackling little air bubbles right under the skin, and tracheal deviation away from the affected side. What should the nurse do? So the nurse should immediately release the chest wound dressing and contact the healthcare provider. And this is a medical emergency requiring possible needle decompression and chest tube. So again, that even though that wound is open to the air, with it closed, that's not really helping anything either. And so we want to get ready for needle decompression, putting a needle in there, and probably actually just putting a chest tube in. So pleural effusion, this is a lot more common than a pneumothorax. Any of you that end up working in oncology or yeah, I guess that even a pulmonary floor, you'll see this. It's a collection of fluid in that pleural space. And remember, that's the space between the lining of the lung and the lining of the chest wall. And normally that pleural fluid that's in there is removed by the lymphatic system. So depending on what's going on with the patient, you can have different kinds of fluids in there causing that effusion. Effusion just means a collection of fluid. It doesn't say what kind of fluid. So it could be blood, it could be lymph, it could be pus, it could be all kinds of things. So here's some examples of the types of pleural effusions. And again, I don't expect you to know that necessarily, but good to kind of know. And it could be unilateral, meaning one side, just one lung, or it could be both sides, it could be both lungs. So again, if you have something maybe they have really bad ascites and it's actually coming up, around the diaphragm and causing problems, you can have issues there. Okay, so chest tube we put in, and a chest tube returns negative pressure to the actual space, and you can see here's the air drainage tube, right? And then you should also have a blood drainage tube, and it removes the fluid or the air that's in there. I am not going to go any deeper than that for a chest tube in this particular course. So pulmonary edema, this is excess watery fluid in the lungs. Think of it as fluid down in the alveoli, and it interferes with that oxygen blood exchange. We mostly see this with like left-sided heart disease, where remember the left side isn't working so well, so the lungs become the place where this fluid backs up, right? You can also see it with ARDS, inhalation of toxic gas, and even pathogens. Again, COVID is another good example. And we don't do well with fluid in our lungs. It's not where it's supposed to be. And so you'll have dyspnea, difficulty breathing. That's what dyspnea means. Dys is bad, and pnea is breathing. So bad breathing, crackles. You'll hear almost like if you take your hair and rub it between your fingers right next to your ear, that's the sound of crackles. You'll have a VQ mismatch, again, where not the right mix of air to blood for that transfer of oxygen. Frothy pink sputum, hypercapnia, again, high CO2, right? And so the best thing that we can do here is diuretics. Let's make them unwet. If they're wet, let's make them unwet and get some of that fluid off. And then vasodilators and supplemental oxygen. And all of those things tend to make it easier for the person to breathe. A vasodilator is going to make it so that it's much easier for the heart to pump against that systemic pressure, right? If those vessels aren't as clamped down and they're a little more relaxed and open, it's easier for the heart to pump, which then means we're not going to have the backup of fluid in the lungs, et cetera, et cetera. Okay, so here's another little schematic of pulmonary edema and some of the different pathways that can lead to pulmonary edema. So again, I'm going to let you look at that on your own. Yeah. ARDS, this is spectrum of lung inflammation. So it's just acute respiratory distress syndrome. That is very generic. It does not tell you why, right? It just says that they're having major league problems with their lungs. And so there's some things that can happen in here, but we do know that there's massive pulmonary inflammation. Injures the alveolar capillary membrane, right, and produces severe pulmonary edema. So now we have those wet lungs. There's a VQ mismatch, which makes sense, and hypoxemia. And so if the patient has sepsis, it can actually be chemical mediators that cause widespread inflammation. So remember, sepsis is where we have some kind of bacterial, usually bacterial infection that has gone systemic. It's everywhere. It's in all the organs, and the body is just like in total crisis mode. The alarm bells are going off like, oh my God, you got to do something or I'm going to die. And so it leads to the systemic inflammatory response syndrome, which can then lead to multiple organ dysfunction, and then that can lead to respiratory failure. Sepsis is rough and it's hard to turn around. So there's an exudative phase in the first 72 hours. But if we can't figure out the cause of this ARDS, or we can't address the underlying cause, we end up moving into this proliferative phase and then to the fibrotic phase. And I think the important thing is to know that the longer someone's on a ventilator when they're in ARDS, the more damage is being done to the lung tissue for the long term, right? And so it leads to fibrosis of lung tissue. And that's why sometimes even on a ventilator, people will be like, oh, they can live forever. Well, they can't, because eventually that lung tissue is not going to function. It won't matter how much air you pump in there. It will no longer work. So this is where we have to make some hard decisions sometimes. Okay. So it's a clinical syndrome. It usually has a very rapid onset. Think 12 to 18 hours. That's like a shift or a shift and a half, right? And it has a high morbidity, meaning a high rate of death. Sorry, that's mortality. Morbidity means a high rate of disease. Sorry. So it causes aspiration. Causes of ARDS is aspiration, toxins, drugs, infections. Remember we talked about sepsis, damage to alveolar cells. Think about like breathing in smoke from a fire, shock, trauma, DIC, which is disseminated intravascular coagulation. You don't need to really worry about that. Blood transfusions can actually lead to ARDS and sepsis. Again, just know the syndrome. Don't be so wrapped up in all of the things that cause it, because there are a lot, right? And treatment is oxygen, mechanical ventilation, that Fowler's sitting up position, restricting fluids. So they're already wet. You don't want to make them wetter. And diuretics to offload some of the wet, and corticosteroids to decrease the inflammation. You can kind of see the cascade of events that happens here that lead to death. Pulmonary emboli. Pulmonary emboli, an emboli is a clot of some sort. And it could be and it's a clot that's on the move. Does that make sense? So pulmonary emboli usually are clots that come from somewhere else. Oftentimes people's calves, right? They'll have a deep vein thrombosis down in their calf, and then it moves and it'll go up through the, venous vasculature into the right side of the heart, and then into the pulmonary vasculature where it gets stuck, like here, okay? And then everything that is downstream from that, that is fed blood from that particular branch, it could potentially die. So the higher up the clot, the worse the damage, because it's going to block off all of this. So it's the risk factors are venous stasis, cancer, hypercoagulability, trauma, and then just genetics. And trauma, you're like, why would trauma do that? Well, our body's in a healing mode. It's in a fixing mode. And some of fixing sometimes is clotting, right? So, and then cancer messes with your coagulation factors. Venous stasis just means that we're not moving the blood through the venous system as fast as it should be moved. And so like when we're sitting on an airplane with our knees bent and there's no leg room, you can't stretch your legs out, this is where people can get DVTs. The symptom of a PE is sudden onset of chest pain, dyspnea, tachypnea, anxiety, fainting, shock. It's done with a D-dimer. We do a D-dimer, which is a blood test, and we look for a certain level of D-dimer, and if it's elevated, we're worried about an emboli, and then we look at a CT scan. Again, that will help us to see what's going on with the tissue. And just want to also bring up here, I don't know if you have talked about this yet in your maternity lectures, but a substance, right? A substance can be an emboli as well. So could be tumors that break off and travel through the bloodstream, bone marrow, amniotic fluid, which is really interesting. And when you hear about maternal death, at least in the United States, it's often due to amniotic fluid embolism. It's extremely rare, but it happens. You have all these blood vessels leading to the uterus that are, open. You've just had a baby sort of torn out of that system. It's separating from the uterus and getting ready to be birthed. But we know that that's a bloody procedure. And while the mom is pushing, amniotic fluid can actually go from the uterus into the bloodstream and can cause an emboli. And that is actually, quite highly fatal. So very, very scary. You need a rapid response team, heparin therapy, maybe an antithrombotic, something like a clot buster that can be given. Those have to be given with a lot of caution, though, because they can also cause tremendous bleeding. So clients experience pulmonary embolism. The nurse should assess for which symptom which is most commonly reported. And the answer here is chest pain that occurs suddenly. So if you think about it, the patient feels fine until that clot traveling silently through, the vasculature makes it to their lung, and all of a sudden now you have that severe VQ mismatch. You have tissue that's ischemic, not getting enough blood. That causes pain, and so that's why they have chest pain that occurs suddenly. And you'll see people actually like clutch their chest or complain like, I can't breathe. Okay, so again, most common initial symptom is chest pain. Next one is dyspnea, which makes sense, right? They're going to have pain and then they're going to figure out that they can't breathe, which will lead to an increased respiratory rate. And then you're going to get apprehension, restlessness, tachycardia, cough, cyanosis. And then behind here is death if we can't do anything about it. Nurses assessing respiratory sounds of a client who suffered a fractured rib. The nurse should expect to note which finding. What do you think it is? They have a fractured rib, so it really, really hurts. Okay, so pain, especially with inspiration. If you think about that, that you're going to be separating those broken pieces from each other and coming back together. Be very, very painful. Let's see. I'll let you read this on your own. COPD. Okay, COPD. COPD is very common, chronic obstructive pulmonary disease, and it's preventable. It's a chronic inflammatory response in airways and lungs to noxious particles or gases. So does that tell you what the issue is? Primarily it's to cigarette smoke. So there's two diseases that kind of make up this condition, and it's emphysema and chronic bronchitis. So again, most common cause is cigarette smoke, but it could be environmental fuels, pollution, and then of course just a genetic propensity for developing COPD. It's characterized by chronic obstruction to pulmonary flow, inflammation and fibrosis of the bronchial wall, destruction of the cilia, right? And loss of elasticity is a big one, and this VQ mismatch that results. So there's increased resistance to airflow and gas exchange. So that's part of the obstructive, right? Chronic obstructive pulmonary disease. Chronic bronchitis is hypersecretion of mucus in the lungs, and it results in air trapping in the alveoli, mucus hypersecretion, and decreased mucus clearance, right? So it's producing lots of mucus, it's stuck in there, and it can't get out, and it leads to a chronic productive cough. If you've ever heard somebody who has this, it's a really wet, gloppy sounding kind of cough, and unfortunately, just doesn't get better. Again, they've had some kind of an inspired irritant that causes airway inflammation, and that leads to infiltration of neutrophils, macrophages, and lymphocytes, which then causes bronchial edema. You have an increase in the size and number of mucus glands and goblet cells. Remember, goblet cells make all that mucus. And then you have a thick, tenacious. Tenacious means kind of super sticky, really strong bonds, not easy to thin or break apart. And that makes it really hard to clear. And also then you have impaired ciliary function. Remember, ciliary are those little hairs that line the respiratory tract that also helped carry mucus out of the way. So here's just sort of a visual of all of that. And again, you can see, mucus plugs here, hyperinflation of the alveoli. This really just kind of brings it right home. So air can come in during inspiration, but it's harder to get it out during expiration. You have muscles that are squeezing, right, during expiration to try to force air out. But unfortunately, you have these hyperinflated alveoli right here. And so the air just gets trapped in here. And of course, then now you have CO2 in here, and you have someone who's not very well oxygenated. Emphysema is abnormal permanent enlargement of gas exchange airways with destruction of the alveoli, of the walls of the alveoli. And it's a loss of lung elasticity. It results in a VQ mismatch. Again, you have air trapping. Remember we talked about AP diameter, that's the anterior posterior diameter of the chest, kind of the front chest wall to the back. And they end up having sort of this barrel chest where that AP diameter is increased. And so instead of our bodies looking like kind of a big oval, if you were to take a kind of a slice, like a CT scan, it would be more like, closer to a circle. And then they maintain their oxygenation, right, their PaO2 by increased ventilatory effort until late in the disease. So these are people who are chronically short of breath, tachypnic. I mean, it's really pretty a miserable thing. So here you go, destroyed lung tissue, and you can see this hyperinflated alveoli here, but also the mucus and everything has just destroyed the bronchi as well. And then you have all of this black, looks like deposit, probably from smoking in here, which is just horrifying. So again, this is that AP diameter that I talked to you about. You can see here's kind of that normal oval shape, and then here's more of that kind of heart shape, or almost a circular shape in a barrel-chested patient. You can see this when you see, folks have their clothing off on top. This will become a lot more apparent. So what happens? You have progressive COPD. And there's increased work of breathing, hypoxemia and hypercapnia lead to air hunger. You have air trapping and hypersecretion, which leads to more inflammation and fibrosis. So it's kind of a vicious cycle that just repeats itself, and one round of the cycle just sets you up for the next round. So the only way that we can treat this is to slow down the inflammation. So we can do that with steroids and then stop the initial insult, such as smoking. But I will tell you, it's not unusual to see people with COPD still smoking to the end. They're kind of like, oh, what the heck? I'm already this far. This is a vice I enjoy, and if it's going to kill me, it's going to kill me. So clinical manifestations, again, it's often a combination of emphysema and chronic bronchitis together. This prolonged expiratory phase, because remember, as you're breathing in and out, as you're trying to breathe out, that air gets trapped in there. You have tripod positioning, pursed lip breathing, productive cough, dyspnea, wheezing. Again, there's often a history of smoking. Barrel chest, cyanosis, chronic hypoventilation. And as a compensatory mechanism, we talked about polycythemia, where the red blood cells try to increase in number, like, hey, we're going to increase our oxygen carrying capacity so that we can get, oxygen around the body if that's the problem. But the problem is it's not the carrying capacity, it's the oxygen that's actually getting to the blood itself. Okay, so here you go. Here's kind of a side-by-side bronchitis emphysema comparison. And again, not sure that I really care that you know the difference between these two. I want you to know that COPD has no cure, and really all we can do is slow down the process and optimize function, right? So we want to decrease their exposure to infections, making sure that they're immunized for the flu and for pneumonia is really important. These are people who don't fare well when they get those diseases. They need oxygen eventually. These are the people dragging around an oxygen tank, 1 to 2 liters per minute. And we keep their O2 sats at about 90%. If we over-oxygenate them, remember, they have this hypoxic stimulus for respiration. So if we reverse this hypoxia too well, then we'll lose this stimulus for respiration. So that's why we want to be careful here. So treatment, chronically, they're going to be on bronchodilators or other respiratory meds, anticholinergics, leukotriene inhibitors. They could be on xanthines, aminophylline or theophylline, but I'll just tell you that these drugs have high toxicity And so they're not something that are used as, certainly not as a first line treatment. Maybe they get used down the road when we're kind of, you know, just sort of throwing things at the problem because we don't really have any more options. And then acutely, if they have an acute exacerbation, you know, antibiotics, steroids, and oxygen, but again, using that very cautiously. So the nurse is instructing the hospitalized client with a diagnosis of emphysema about measures that will enhance the effectiveness of breathing during dyspneic periods. Which position should the nurse instruct the client to assume? And hopefully by now you have realized that this tripoding position is not only preferred by the patient, but the best for improving airflow. Okay. The nurse is caring for a client hospitalized with acute exacerbation of chronic obstructive pulmonary disease. Which finding would the nurse expect to note on assessment of this client? What do you think? Hypocapnia, that would be low CO2. I would say that's a no. A hyperinflated chest, remember barrel chest noted on chest x-ray? I'd say that's a yes. Decreased oxygen saturation with mild exercise would be a definite yes. So any exertion that increases your need for O2 will exacerbate the problem. A widened diaphragm noted on the chest x-ray. I don't believe that's part of it. And then pulmonary function tests that demonstrate increased vital capacity. Increased vital capacity. Here's the key word that's incorrect. It would be decreased vital capacity. So there you go. But apparently not on pulmonary function tests. And I'm sure this will, there you go. So the nurse instructs the client to use the pursed lip method of breathing, and the client asks the nurse about the purpose of this type of breathing. The nurse responds knowing that the primary purpose of pursed lip breathing is to promote which outcome? What do you guys think? Yeah, so it's to promote carbon dioxide elimination. When you do pursed lip breathing, you provide resistance as the patient is expiring. So just think about it. You can do it yourself, where you're putting your lips together. And that helps get CO2 out of the airway. Okay, medications. These are, I have done separate PowerPoints for you on medications. You can go ahead and look at those. And let's just talk about some of the principles of medication administration. So here's some kind of guidelines to follow. And that is, if two different inhaled medications are prescribed, instruct the client to wait 5 minutes following administration of the first before inhaling the second. And that would be to give that first drug opportunity to work and do its thing before you sort of lay down the medicine from the second inhaled medication. If a second dose of the same medication is needed, instruct the client to wait 1 to 2 minutes before taking the second dose. So here's an example of taking maybe an albuterol inhaler. Someone's wheezing, they're really feeling short of breath. They take one puff. Rather than taking one puff, blowing it out, and then immediately taking another puff, we're going to wait. Again, let that first puff do some bronchodilation or whatever it is that the medication is doing before you put more medication down. And then this third one makes sense in light of the first two, which is if one is a glucocorticoid and the other is a bronchodilator, do the bronchodilator first. If we do the bronchodilator first, we're likely to get a lot more glucocorticoid down into those crooks and crannies of the lung tissue as those bronchial tubes open up. A metered dose inhaler, this is like pretty typically what you see probably if you have friends who have asthma or you yourself take an inhaler. It's the small inhaler that, you push down on the canister and it delivers a specific amount of medication. There are also some dry powder inhalers. A lot of these tend to look round, like Advair can look that way, although Advair now comes in a metered dose inhaler. But again, it's mixing, it's popping a little packet, a little foil packet inside that releases that powder, and the patient has to inhale quickly in order to get that down into their lungs, because there are no propellants that help get that, there's nothing that sprays the medication out. It's really dependent on the patient breathing in. And then nebulizer, which delivers fine liquid mist of medication. And there's a little cup, usually with liquid in it. And then we hook it up to oxygen, and that aerosolizes the medicine in that cup, and the patient can breathe it in and out. And it's really probably, of the three of these, the most effective in terms of getting medication down. So if somebody's really sick, they come into the hospital with breathing issues, they'll usually get a nebulizer. Bronchodilators, the two that I want you to really know are albuterol and salmeterol, and the major difference between those two is albuterol is fast acting. You're wheezing, you can take it right now. It's going to help you feel better right now. Salmeterol is a long-acting beta-2 agonist. It is going to take much longer to work. It works, but it's more of an extended, like an extended release. And I will let you look at the mechanism of action here, but this is really, I'd say, it's sort of the cornerstone or keystone of asthma treatment as we think about it. And remember, these are beta-2 adrenergic agonists, so they stimulate the sympathetic nervous system. And you have one heart and two lungs, so beta-2s are in the lungs. So here's those receptors, and again, this is just a visual, so I'll let you look at it, but love this picture right here. This really describes, look how big the airway is here, and here, look how big it is once you have all of this bronchoconstriction combined with mucus. You can see why people's lungs wheeze and whistle when they're having an asthma attack versus once they've taken their inhalers and coughed up the mucus in there. It's a marked difference as a patient how you feel between these two pictures. Okay, so who shouldn't get a bronchodilator? Well, this is again one of those risks versus benefits discussions, right? So again, I would say that, you want to look at this list. You don't need to memorize it completely, but you want to be careful. Severe cardiac disease, especially because, again, you're going to, even though it's a beta-2, you're going to have some beta-1 kind of cross stimulation. It's not intentional, but it happens. And that beta-1 can cause things like palpitations, dysrhythmias. Remember, we talked about people, especially after they get a nebulized albuterol treatment in the emergency room, they might be like kind of tremorous, shaky, kind of restless, kind of feeling kind of buzzed. And that comes from that beta-1 cross reactivity. So people who have heart issues, we just kind of need to pay attention to that. I'd say that's your biggest one that you really need to watch with this. So you want to assess vital signs, especially lung sounds. If you're going to get a breathing treatment or an inhaler, listen to their lungs before, listen to their lungs after. But again, it depends on the drug. If it's a long-acting beta-2, you might not hear much difference afterwards, or even a corticosteroid, right? You want to assess for cough, wheezing, decreased breath sounds, sputum production. There are times when the patient's so incredibly sick that these bronchodilators really, they kind of hit like a ceiling effect where they don't really work very well anymore. And so if a patient tells you, oh, my inhaler is just not working anymore and I'm really feeling bad, that's someone who needs to come in and see a provider, because we need to try some different medications. Maybe we try an anticholinergic like atropine. So they need to come in and be seen. Adequate hydration is really important because, again, there's mucus trapped in there. We want to get that mucus out. So liquefying that and moisturizing that helps us expectorate it and get it up. And then you want to administer the medication at regular intervals around the clock. Again, we don't want to, open someone up and then let them sort of sink back down to being totally bronchoconstricted again before we give more meds. We want to sort of stay on a regular schedule so that we can optimize their breathing. Again, oral theophylline, I don't think you really need to know this. It's not given very often anymore because of its toxicity, and it's not something that I'm going to ask you on a test for sure. Let's see. We've already talked about this for the most part. Yep. Oh, sometimes there's combinations of albuterol and Atrovent or ipratropium. And yeah, it works really well. This combination is used a lot for COPD. Salmeterol. Remember how I told you about a disc, a dry powder inhaler? This is a dry powder inhaler and does not have a propellant in it. So this is a long-acting beta-2 agonist. You can call them LABAs, but I can tell you that clinically I don't hear that. But I'm not a respiratory therapist. I'm a nurse. So, but again, it's selective for beta-2 receptors, but it is long-acting, right? So it's interesting, there's a black box warning for this drug. And the black box warning is that LABAs increase the risk of asthma-related deaths and should only be used in patients as an adjuvant therapy in patients who are currently receiving but not adequately controlled on an inhaled corticosteroid. Okay, so what this means, I'll take all this gobbledygook and tell you that people should not be taking this on their own just as the only drug they take, okay? It really needs to be taken in conjunction with a steroid, which is why a drug like Advair, where you have fluticasone combined with salmeterol, is a much better choice. Now, maybe somebody started on an inhaled steroid alone, that's fine, and it wasn't enough, and so now they're used to that, and now their doctor's going to add salmeterol as another treatment, an adjuvant, which means another that kind of comes alongside and treat together, and the patient just, is used to taking one kind of inhaler, so you do, their steroid with one inhaler and their salmeterol with another. But if you can get them to switch over, Advair will deliver both in the same inhaler, which is awesome. Ipratropium or Atrovent is an anticholinergic. And again, remember, an anticholinergic works a lot like a sympathomimetic. So this is going to work a lot like albuterol. Just has a different mechanism of action. It's working on acetylcholine receptors and blocking those. So again, it's muscarinic receptors, so not beta-2s, muscarinic. And used for COPD, asthma, exercise-induced bronchospasm. Very similar side effects to what you might see with the other ones. But remember, you just want to be aware that this is, a slightly different drug. It's an anticholinergic, so it's anti-rest and digest. Okay. Glucocorticoids, i.e. steroids, folks, right? our friend, remember our friends, prednisone, beclomethasone, prednisolone. Do you see all the zone in these? That means they're glucocorticoids. And, you know, we can look at all of these. I made beclomethasone your prototype to learn, but essentially they're anti-inflammatories, and they prevent the release of these inflammatory mediators like leukotrienes, prostaglandins, histamines. We've learned about all of those. And prevent the action of cells responsible for inflammation. So it sort of turns down the action of leukocytes and eosinophils and says, just chill out a little bit. Don't get so excited when you see something that you think is foreign. And that decreases edema in the airways. So again, really potent anti-inflammatory response, which leads to all of these other kind of this sort of fallout of all that is decreased histamine, decreased capillary permeability, decreased migration of polymorphonucleocytes, polymorphonuclear leukocytes, sorry, and IgE synthesis. And IgE is synthesized in response to an allergy. So again, budesonide is the drug that's given here, but we're going to do beclomethasone, and the side effects are very, very similar here. And remember, if you're going to take this as a separate inhaler, but you're also, you know, on a beta 2, you'd want to take that beta 2 first. The other thing is rinsing and gargling afterwards is important. And again, any steroid taken orally that lays down on those tissues may lead to something like an opportunistic infection like candidiasis or thrush, better known as thrush. So you want to have them rinse their mouth out when they're done taking it. And then they should also use a spacer with it. So something to remember as well. Prednisone, we've already talked about, so I'm going to go past that. Nursing interventions for prednisone. Folks, you really need to know this slide. If you don't know this slide, you really need to know this slide. You know, we want to monitor for hyperglycemia. That is a side effect of prednisone. We want to look for signs of infection. So we had a question on one of our tests about fever, and it was one that many people missed. A fever should tip us off that maybe there's an infection going on, and if our patient's on prednisone, we shouldn't be surprised. We want to look for sodium retention and hypokalemia that can happen as a result of being on prednisone. Weight gain, for sure. Fluid and electrolyte balance, you're going to watch that as well. So these are the things that you really, really want to look at. And yeah, just something that you should know. So here's more about prednisone. Now, when we use prednisone in respiratory things, it kind of depends on why we're using it. Are we using it because this is an asthmatic who's just really in a bad way, and they're taking all their meds, but they just can't quite kick this asthma exacerbation? Well, then this orally twice a day for 3 to 10 days is awesome, right? If it's less than 5 days, they really don't need a taper, but if it's more than 5 days, they should have a taper where they, you know, maybe today you take 40 milligrams, and then tomorrow you take 30, and then you take 20, and then you take 10, and then you take 5. So again, it gives the adrenal glands a chance to sort of jump back into action and make your own cortisol, because once you start giving prednisone, you know, as a pill or liquid or IV or however you're giving it, apart from just inhaled, I would say, inhaled doesn't really go systemically, but if you're giving systemic prednisone, your adrenal glands are going to be like, cool, I don't need to make any. Well, I got some coming in from another source. So if you're going to stop giving it to them, you have to stop it slowly. Okay? So, client has prescription to take guaifenesin, Mucinex. The nurse determines that the client understands the proper administration of this medication. That's important. If the client states that he or she will perform which action, take an extra dose if fever develops, take medication meals only, take tablet with full glass of water. Ding, 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 we want water, right? Because remember, guaifenesin is an expectorant, and it's going to loosen mucus and help get it out, but it needs water to do that. And then decrease water intake, nah, it's not going to work. Nurse has a prescription to give a client salmeterol and beclomethasone by metered dose inhaler. The nurse should administer the medication using which procedure? So what med are we going to give first, guys? We're going to give the salmeterol first because that's the bronchodilator, and then the beclomethasone. Okay? Although I have a little bit of an issue with this question because salmeterol is a long-acting beta-adrenergic, a LABA. And remember that this isn't going to cause immediate bronchodilation, but we'll just go with the theory that we should do that first. That is it, gang. Thanks for hanging in there with pulmonary. I think between part 1 and part 2, you have everything that you would need to know for pulmonary medications, along with the pulmonary medication PowerPoints. You have everything you need to know for pulmonary. And if you want to go back and look at or listen to the lectures recorded by Dr. Isaacson for the H&P part, you can do that. But I think we pretty well cover it in these lectures. All right, thanks for your attention.